Uh, okay, Assalamu alaikum and good afternoon to all our viewers. I'm Dr. Vasfai Jas and I'm working as assistant professor and consultant endocrinologist at Jinnah Postgraduate Medical Center and Jinnah Sindh Medical University. So I welcome you all on behalf of Pakistan Endocrine Society in our today's webinar on clinical practice guidelines on pituitary adenoma management. So these guidelines, which are recently published by Pakistan Endocrine Society with extreme efforts by Pakistan Endocrine Society president and scientific executive members. So these guidelines basically highlight the importance and the need uh, for the increased awareness and education among healthcare professionals and general public. So additionally, they also emphasize the importance of developing more affordable and accessible treatment options for low income countries. So, overall, these guidelines provide the comprehensive framework for managing conditions considering unique challenges and resource limitation in low income countries. So, two previous webinars have already been conducted on Cushing's and non functioning pituitary adenomas. Today is our third webinar where we will be discussing the guidelines regarding acromegaly. And to proceed with our session, I would like to invite our esteemed panel of experts, Dr. Aisha Sheikh, who is consultant endocrinologist at Aga Khan University Hospital, and she is also president of Pakistan Endocrine Society. Then we have Dr. Najmul Islam, who is also consultant endocrinologist and professor of endocrinology at Aga Khan University Hospital, and he is also one of the founding members and past president of Pakistan Endocrine Society. So I welcome to both of our esteemed panel of experts. Welcome on board. And then next, I would like to invite our expert speaker, who is also one of the author of the guidelines, Dr. Uruj Lal Rahman. She is currently working as associate professor of endocrinology at Jinnah Postgraduate Medical Center in Jinnah Sindh Medical University. She is also in charge of endocrine department there and also one of the scientific executive members of Pakistan Endocrine Society. So I welcome you, Dr. Ruj, to the program.
Thank you.
So into our today's program, we'll start with the pre-test. So there's going to be a pre-test. You can attempt that, and then we will formally start with the presentation.
The blood pressure is 140 by 90. There's a zero missing there. So anyone ये कहीं सेल्फी पकड़ा क्या करते हैं
Bhai, I cannot hear anything. Is what's happening?
So there is a poll going on.
Yeah. Sir, poll is being done. There is a pre-session quiz, 3 questions.
So we should start with presentations now, or you'll discuss it after presentation, the polls.
ये तो बाद में आप डिस्कस करेंगी ना?
जी.
Ask Aisha how does she want this to be done? You want to discuss them या दोनों को compare करोगी at the end of the presentation?
Yes, so Vasfa, you will be having the post quiz and then post test quiz, and then there will be a comparison, and we can discuss if there are any queries and confusion in those questions till and that.
So once this quiz is over, I'll just invite Dr. Rooj for the presentation.
The quiz is done.
Okay. Okay, so the quiz has been finished and the polling time has ended. So we'll now formally begin with our presentation, and for the presentation, I would like to invite Dr. Rooj Lal Rahman to start with her presentation, and then there will be a post test as well after the presentation. So you have to be really attentive during the presentation. Over to you, Dr. Rooj.
Thank you, Vasva. Just let me start this. Okay, ji. Assalamu alaikum, everyone. I'm Dr. Rooj Lal Rahman. As Vasfa has just introduced me. I'm very honored to be here talking about the pituitary adenoma guidelines, which I was part of while writing under the leadership of Dr. Nazim and Dr. Aisha Sheikh. As Waspa has already said that these clinical practice guidelines were basically made keeping in view of our country and the resources, the limitations we have. So 2 webinars already has been done, one for the prolectinoma and one for the non-functioning adenoma. And now we are going to do the 3rd chapter, that is, okay, I'm so sorry. Okay, so we were talking that we are going to be talking about the acromegaly guidelines by the Pakistan Endocrine Society along with the Pakistan Society of Neuro-Oncology. So next. So initially, first thing, what is acromegaly? Acromegaly is a chronic disorder which is caused by a growth hormone secreting pituitary adenoma, leading to raised insulin-like growth factors. And this raised IGF-1 then results in a progressive disease characterized by the somatic growth, leading to disfigurement and multiple comorbidities, which in turn cause early mortality as well as morbidity. Next, please. So when we talk about demographics, the age of presentation is around mid-40s, and both sexes, the male and the female, both are equally affected. The prevalence of acromegaly in Pakistan is 7.6% for pituitary macroadenoma and 14% for microadenomas. When we look at the signs and symptoms, so if we go in a descending order, the most common presentation is the enlarged acral skeleton, followed by the facial changes. So the patient will come and say, okay, there is a change in face. People are saying that your face has changed. Then there is a complaint of increased perspiration, joint pains, headaches, hypogonadal symptoms. Usually, people are not that open about these symptoms. we have to ask them about them, but 38% of patients do suffer from this. Visual defects, which all of us know, as a patient of acromegaly will have a bitemporal hemianopia, but we need to remember that this occurs when the tumor has grown pretty large. So before that, the facial changes and acral changes will be there, followed by tiredness, weight gain, and galactoria in a very low number of patients, but still there is galactoria in these patients as well. Next, please. So here we can see some of the features. So there is enlargement of the nose and thickening of the fold, with thickening of the lip. There's prognathism, we can see. I especially put this picture of this woman. She was a British woman who was a nurse by profession, was a widow having 4 children and was having difficulty earning. So she had entered into contest for ugliest woman of the world, and actually she had acromegaly. So a sad story behind it, but yes, if we are not able to diagnose them in time, there were times when it was not diagnosed in time, but now we can diagnose and treat it in time, and don't see. We still do see internationally. People don't see this kind of acromegaly. We still do see this kind of acromegaly in our settings. Next, please. So coming to recommendations of the guidelines, from the guidelines of Pakistan Endocrine Society and Pakistan Society of Neuro-Oncology for the lower income countries. First thing is the diagnosis, please. Next, please. So the first recommendation is that all patients who are presenting with typical clinical features of acromegaly, and if they are coming with a pituitary mass, we should have measurement of IGF-1 levels. So a patient who has clinical features of acromegaly, you get an IGF-1 levels. And sometimes patients, they are presenting with a pituitary mass, they have headache and some MRI was done, for pituitary was done, and there is a mass there. Again, IGF has to be done in those patients as well. IGF-1 levels matched for sex and age are excellent screening diagnosis for screening, diagnosis, and monitoring. Please remember, random growth hormone should not be performed. It will not guide you, and it will be just waste of money of these patients. Growth hormone has peaks and troughs. The patients with acromegaly will have raised growth hormone levels, but random growth hormone is not the gold standard, or is not a test which should be done to diagnose these patients. Further confirmation is done by doing 75-gram OGTT, but especially in the patients who have acromegalic features but have normal or equivocal IGF levels, or the levels are not more than 1.3-fold increase the standard upper limit, then it is the time to go for 75-gram OGTT. If a patient has acromegalic features and there is raised IGF, we don't need to go, we don't need to do the OGTT test. Next, please. So the test protocol is to give the patient 75 grams of glucose orally, and then you measure the growth hormone and glucose level at 0, 30, 60, 90, and 120 minutes. Acromegaly is diagnosed if the growth hormone concentration increase is more than 1 nanogram per ml or 1 microgram per liter. In normal person, growth hormone level falls to less than 1 nanogram per ml within 2 hours of taking the glucose. So glucose causes suppression of the growth hormone levels. And if it doesn't happen, then the patient is acromegalic. The test is not recommended in patients with typical symptoms and features and raised IGF-1 levels. It's very costly, cumbersome. So if there are typical features and the levels are raised, no need to go for this test then. Next, please. Then we have to do a radiological diagnosis. We need to get an MRI done to see the adenoma, to see the size, is it supracellular, where the extension, what is it doing with the optic chiasm, what is it doing with the cavernous, how the things are. And it will also guide us towards the further management of the patient. Next, please. So perimetry, visual perimetry is very important, and to rule out the compression of the optic chiasm, it will bitemporal hemanopia is typically seen in large tumors. It is important to know so that we can see how the treatment has helped the patient. Next, please. Other pituitary hormones, very important because the tumor might be causing compression of the other hormone producing cells. And leading to hypopituitarism. So TSH, FT4, ATM, cortisol, the FSH, LH, testosterone, and estradiol in females, of course, this need to be done. So if the excesses are suppressed, we know these excesses are not working, and we can treat this patient before proceeding with the further treatment option that is usually the surgery. Serum prolactin is also very important because most of these tumors, they are co-secretory. So acromegaly patient can have a co-secretion of prolactin. Sometimes when you treat these patients, the prolactin levels start rising as well if you are not treating it. So, and vice versa. So these tests, other hormones definitely need to be done for the evaluation of the patient. Next, please. So not only hormones, we have to look for the comorbids. Acromegaly can lead to hypertension, diabetes. It can affect cardiovascular diseases. It can lead to osteoarthritis, sleep apnea. So we have to evaluate all these patients for these comorbids. Not only that, but the thyroid enlargement can also occur. So we have to look for the thyroid nodule, palpate for thyroid nodule, and do a thyroid ultrasound is needed. A colonoscopy is very important because there is increased risk of colonic neoplasia. So at the time of the diagnosis, diagnosis of acromegaly, a colonoscopy has to be done in these patients. Next, please. So what should be the goal of the treatment? What do we want to achieve from this treatment? We want to achieve sex and age normalized serum IGF-1 levels. After which we have to do an OGTT suppressed growth hormone level, which should be less than 1 nanogram per ml. This is for first generation assay, and internationally, the third generation assay is available, which leads to 0.4 nanogram per ml. At the moment, we are recommending 1 nanogram per ml because we don't have the third generation assay. As soon as this is available, we will be recommending the levels of 0.4 nanogram per ml. Reduction in size of pituitary adenoma as well as its local mass effect, that is the goal as well. So again, the improvement in signs and symptoms of the disease, improve medical comorbidities, hence leading to improved mortality, in the maintenance, and then maintenance of overall pituitary function. So wherever panhypopit is there, it has to be treated and has to be maintained. Next, please. So now coming to the management. Next, please. So we recommend first line therapy, which is recommended is surgical. This is recommended internationally as well. The preoperative factors which are predictor of a surgical cure are the size and appearance of the tumor on MRI. So MRI pituitary not only tells where the tumor is, it also predicts that how much surgical intervention will help us. Growth hormone and IGF-1 levels are also improved in it, will also be improved by it. So, sorry, the growth hormone and IGF, the higher the levels, it also predicts the outcome of the surgical procedure. For giant pituitary adenomas, which are more than 4 centimeter, transsphenoidal surgery alone might not be helpful. And in that case, we might need a transcranial surgery. So mainly it is the transsphenoidal surgery which is done nowadays. You go to the sphenoidal sinus to the pituitary gland. But in cases where the tumor is very large, more than 4 centimeters, then a transcranial resection is also done. So 2 surgical procedures might be needed. And the very important thing is that the neurosurgeon who's doing it has expertise in these surgeries. There has always been a discussion about giving preoperative somatostatin analogs. Studies have shown no role, and so we are not recommending them. So first-line therapy, acromegaly patient, first-line therapy, send the patient after stabilizing any excess defect, send the patient for the surgical therapy, transsphenoidal or whatever the surgeon decides. Next, please. Post-op assessment is very important. So post-pituitary function must be checked for at least 2 weeks in the immediate post-op period. Very important because patient can go into the salt wasting, and so we have to look into, and the posterior function might be affected. So it has to be done for at least, so electrolytes need to be repeated in this patient to look for any posterior function, posterior pituitary dysfunction. Then posterior assessment of the axis, the hypopituitarism, especially the adrenal axis, if it has to be done after with around 4 to 6 weeks of the surgery, to see if there is any hypoadrenalism and if the patient requires any steroid therapy. Further steroid therapy. MRI pituitary for residual tumor should be done at least 12 weeks after surgery, so that all the edema and everything has settled down because of the surgery. And now we can see that how much the tumor is left behind and what next to be done. Biochemical activity for acromegaly should be assessed at 3 to 6 months by doing an IGF-1 level. And when IGF-1 levels are achieved, the age and sex match IGF-1 levels are achieved, then to confirm it, whether cure is there or not, then OGTT for growth hormone should be done. When will we call a confirmation, a cure? When suppressed levels of growth hormone are less than 1 nanogram per DL, if you're using the old generation assay, which is being used in Pakistan, or 0.4 nanogram per ml, which is for the third generation assay. Hopefully in a year or so, we will be getting the third generation, and then with the recommendation will be same as international, that is 4.4 nanogram per ml. Please, next, please. So the second line, although for us, because of the constraints of because of the unavailability and the price factor of the medicines, and because stereotactic surgery in Pakistan is fortunately available in some of the centers free of cost, in some big centers and free of cost. So we are recommending radiation therapy as a second line therapy over here. However, if medical therapy is accessible and affordable, it remains the preferred second line as it is recommended by the international guidelines. But coming back to our own settings, we have to look at a lot of things, and especially the price factor, which is stereotactic radiosurgery in the form of CyberKnife or gamma knife is recommended in these patients. The eligibility for the radiosurgery is persistent disease despite surgery, and the patients, and then again, this is for the those patients, this is for those patients who will be going to, for if they are going for a medical therapy first. So if they have poor response or intolerant to medical therapy or cannot afford medical therapy, in that case. However, in our settings, I'm again saying, in our settings, we are recommending radiosurgery as a second line after the transsphenoidal or after pituitary surgery, we will proceed to the radiosurgery. Next, please. Then medical therapy. Again, I'm going to repeat this because this is very important. Medical therapy is internationally recommended as second line therapy of the patients with persistent disease, despite surgical resection, or for patients in whom surgery is not appropriate. However, we are keeping it at a third step due to unavailability and financial constraints. So we are giving it after doing the radiosurgery, and we are recommending it as an interim therapy or bridging therapy post radiation therapy till the cure is achieved. So we know that radiation therapy takes a longer time. It takes some time before the cure occurs. So during that time, to control the hormonal effect and to control the IGF levels, this medical therapy is given till the time patient is cured. So we are recommending it as an interim therapy or a bridging therapy. Please, next, please. So medical therapy, we know there's first line and then there's a second line medical therapy. The first line is the somatostatin receptor ligands or analogs. These are growth hormone inhibitors. There are 55% biochemical response, and more significant number of patients have improved symptoms. And they also cause reduction in the size of the adenoma by 20 to 40%. We have two types, octreotide and lanreotide. Octreotide is given 20 milligram per month, and if not responding, then we can increase the dose to 30 milligram or 40 milligram. And lanreotide is 60 to 120 milligram every 4 weeks, or high frequency, that is 21 days. Side effects, diarrhea, the GI side effects, the diarrhea, steatorrhea, constipation, and gallstones. We really have to look for the gallstones. Patients do develop gallstones after these and need cholecystectomy. There can be hair loss, and there can be bradycardia, and then local site irritation and pain. Dopamine agonist, commonest, the acromegaly, which has a very good role in prolactinomas, has also shown to be beneficial in patients with acromegaly, almost in 1/3 of the patients as monotherapy, and it can also be given in combination with sandostatin analogs. It is indicated when the IGF is more than 2.5 than 2.5 of the upper normal limit, then it will be helpful. The dose can be started at 0.5 milligram once or 0.25 milligram twice weekly, can be built up to 1 gram twice weekly. Again, the side effects, similar GI disturbances with postural hypertension, headache, and nasal congestion. Next, please. So there are newer oral somatostatin ligands, oral octreotide capsules, and paltusotine, but there are still studies are going on it. I'm just mentioning here, so we know that there's something out there, and not available in Pakistan, so not recommended. But these are the newer things coming up for the as first line, which will be first line medical therapy for acromegaly. Next, please. Second line medical therapy should be individualized factors which will be affecting second. So a patient who is not responding to the first line therapy or is intolerant to first line therapy, then we move toward the second line medications. But we have to remember in Pakistan, these both drugs are not available. But we're mentioning here because we need to know that these drugs are out there. And once they are available, we will be using them. So, and as they are not available in Pakistan, we recommend moving toward resurgery wherever possible. So factors affecting the choice of the second line medication is if there's presence of residual tumor, we can go for pituitary. And if patient has diabetes or impaired glucose tolerance, then in that case, pegvisomant, which is a growth hormone receptor antagonist, has to be used. And the results with pituitary are very good. 66% of patients achieve control over acromegaly. While with pegvisomant, clinical practice, again, it has been seen 60% control, while in clinical trials, it has shown 90% control. But we have to remember these two are not available in Pakistan. And at this point, we will move toward the option of resurgery. Next, please. So if still biochemical control is not achieved by giving the first line therapy after surgery and first line therapy, our recommendation is to move toward the surgical intervention. So resurgery or intervention has to be done. Combination therapy depends on the availability of the medical therapy, and they show a better result. So if you have given octreotide, so you can add on carbagoline to these patients. So that's how the combination therapy, and it will help the patient. So that's what we can do. Another drug which we can use is a temozolomide, which is a methylating chemotherapy. It can cross the blood-brain barrier, and that is why it has been used in patients for acromegaly. And the indication is malignant pituitary tumors, aggressive pituitary tumors, resistant pituitary tumors, and the results are usually pituitary tumors or acromegaly. The results show the response rate of this treatment is 48 to 65%, and the progression-free survival is 34 months. But the data is insufficient, and the overall survival is still not known. Next, please. So what is the response which we are looking for when we're giving somatostatin analogs? So there's a full response, means normalization of the IGF-1 levels and the growth hormone, and 20% reduction in the size of the tumor in the patients. So patients who are treated with first-line therapy or second-line therapy, or those with no tumor on MRI at baseline. Partial response is a 50% decrease in growth hormone and IGF-1 levels without control, and or a more than 20% and or a more than 20% reduction in size of tumor when treated with first or second line medical therapy. Poor response or resistance is a non-significant fall in growth hormone and IGF-1 levels without control. No reduction in tumors of patients treated on the first line, or there is increase in tumor size in any patient. So this is what we want follow up. We will be seeing the patients for this response. Next, please. Now coming to the comorbids, very important. We have to treat patient as a whole. So just not the acromegaly and the pituitary gland. We have to look at the comorbids. So thyroid at the time of diagnosis, do an examination, look for a thyroid nodule and do an ultrasound if needed, and then follow annually. Any change found should be followed and treated as generally done. For sleep apnea, polysomnography at diagnosis if symptom present, and follow up with effort scale. And if there is severe apnea, then first intensive medical therapy of the sleep apnea 6 months before surgery, because surgery will be very difficult. Intubation will be very difficult in these patients. Diabetes and dyslipidemia, treatment should be optimized. Pasireotide is contraindicated. Pegvisomant is recommended in these patients if we are talking about the second line, but these drugs are not available in Pakistan. And first line drugs, they can be given in these patients. Post-treatment growth hormone deficiency, very important. So when you treat the patient and the patient is cured, with time, the growth hormone levels will fall and they can develop the deficiency. So you have to look at the pros and cons, and whether symptoms, and it depends on the severity of the symptoms. And another thing is the affordability of the patient, because the growth hormone is also very expensive. So it depends on these two things, and we can replace the growth hormone in these patients post-operative. Next, please. So vertebral fractures, very important, they can occur. So we have to look, x-rays need to be done, and underlying causes like vitamin D deficiency, hypogonadism, hypoparathyroidism, they have to be looked at, and treatment of acromegaly needs to be optimized. Cardiovascular diseases are very common in these patients, and so ECG should be done at the time of diagnosis. If there is an arrhythmia, 24-hour Holter monitoring should be done. Echo can be done at the time of the diagnosis as well. For hypertension or diabetes, if there is hypertension, diabetes as well, then regular follow-ups and an echocardiogram should be carried out. If patient has cardiomyopathy, then pre-operative treatment for at least 3 to 6 months is needed, and we should be continued until the growth hormone and IGF levels are reduced. If there is evidence of ischemic heart disease, then a stress test need to be done. There is no consensus. However, dopaminergics, that is the carbapenem, is contraindicated in patients with prior valve disease. Already have a valve disease, it's contraindicated. Next, please. So polyps and colorectal carcinomas, again, very important. A colonoscopy should be performed at time of diagnosis. If there are polyps and adenomas, they should be removed to reduce the possibility of colorectal cancers. So we know that IGF in turn leads to high levels of IGF, in turn leads to growth of these polyps and adenomas. General population recommendations should be followed if colonoscopy is normal and acromegaly is controlled. If the colonoscopy is normal, but acromegaly is not controlled, then colonoscopy should be done every 3 to 5 years. And it should be done as recommended for patients with colonic lesions if the colonoscopic findings are abnormal with controlled acromegaly. Next, please. So hypertension, again, very important. These patients, they develop hypertension, and if hypertension is there, then it will be a problem. So blood pressure should be measured in all patients. Follow-up every 6 months is recommended for patients with active acromegaly and doubtful blood pressure readings. In patients with active acromegaly and hypertension, annual follow-up is recommended. Follow-up after every change in antihypertensive treatment. ACE inhibitors and ARBs are the treatment options recommended. Osteoarthritis and other osteoarticular diseases need to be evaluated and managed at the time of diagnosis and require regular follow-up. Next, please. So these guidelines, they focus on diagnosis and treating acromegaly, a condition caused by excess growth hormone in settings with limited resources. Our challenges are limited access, shortage, the cost of medications such as somatostatin analogs, unavailability of drugs like pegvisomant and pasireotide. The recommended treatment based on availability and cost are first-line surgery, second-line stereotactic therapy, and third-line medical therapy. A combination of the somatostatin analogs and cabergoline are mainly these drugs are mainly recommended alone, but they can also be used as combination in medical therapy. It is recommended that medication should be used temporarily. Can also be used temporarily as a bridging therapy after radiosurgery to control hormone levels until they are stabilized. If the disease persists, surgery is the choice of the treatment. Resurgery is the choice of the treatment. Next, please. So these guidelines prioritize readily available and affordable therapies while aiming for effective acromegaly management. Next, please. So the algorithm which we have come up with is when we confirm a patient with diagnosis of growth hormone secretory pituitary tumor, we have to, next step is the evaluation for comorbids and we treat acromegaly. So and treat accordingly. So we need to treat the comorbids accordingly. First thing is pituitary surgery. After 3 to 6 months, we look for the persistent disease. If he is in remission, which will be normalization of IGF-1 levels, and then we will look at the growth OGTT, a suppressed growth hormone level of 0.4 nanogram per ml or 1 nanogram per ml for us. And random growth hormone, if we do, is less than 1 nanogram per ml, and this will be monitoring these patients after that to see the patient is staying in remission or not. If there is a persistent disease, then we do a radiosurgery. So CyberKnife and Gamma knife. So this is the second line, or a conventional therapy. Then if after that, basically as a bridging therapy, we are using the first line medical therapy. The first generation somatostatin receptor ligands, the octreotide LAR and lanreotide, and cabergoline, especially if the IGF-1 levels is less than 2.5 times the upper limit of the normal. If there is still persistent disease or there is inadequate biochemical control, we increase the dose of the SRL, or we can combine them, or we can go for the surgery. And then there is option of a temozolomide as well. Thank you. Next, please. Thank you. So,
thank you so much, Dr. Ruj, for this outstanding and insightful presentation and providing the comprehensive framework for management, keeping in view that we have the resource limitations, availability, and cost effectiveness of medicines. So we'll now proceed with the post-poll session. Then we will discuss the results, and then we can also take the questions at the end of the session. So please post these post quiz session.
Dr. Vaseva, I mean,
Ji
need
sir.
to go to the next questions because you have to give a limited time and then for the second and third question.
Okay, sir. This is basically the uh, best host is actually uh, collaborating this session.
Okay, ठीक है.
After this quiz session is over, then I'll be taking it over to Dr. Rooj and to the panel of experts for the discussion of this quiz session. And then if there's any question from the audience, then we'll also take that. So are you going to share the results, the admin?
We'll be sharing them in few minutes.
Okay.
Dr. Vaswa, you can take the question and answers in the question and answers box.
Okay. Okay, so we are done with the post-session quiz. Now, if any of the audience have queries or questions related to the presentation, or if they want to clear some concepts, they can just write their message and we will divert it to our panel of experts and the speaker.
So Dr. Vaswa, there are already questions in the question and answers box.
Okay.
If you click on the Q&A box,
There
you
are
will
four
find.
questions.
There's a question that where are the centers where this free surgery is available? Is there any center?
So, yes, public sector hospitals in Pakistan are doing free surgeries for this. In Karachi, we have Jinnah and Civil. They are doing free of cost. In Islamabad, there's PIMS. Similarly, all the public sector hospitals, they are doing whatever have the neurosurgical unit are doing free surgeries. So, yes.
Okay. Thank you so much, Dr. Rooj. So the next question we have is, do we need to manage diabetes and hypertension conventionally or any drug preferences in acromegaly? So,
Can I answer that? Okay. So remember, controlling acromegaly is important because you like to control the growth hormone excess to improve the comorbidities and in general morbidity and mortality. But for hyperglycemia management in acromegaly, till you are going to achieve acromegaly control, you can use metformin safely. You can use GLP-1 analogs because of their cardiovascular benefits. They are beneficial. If GLP-1 analogs are not tolerated or contraindicated because of one reason or the other, DP4 inhibitors can be used. Conventionally, sulfonylureas and thiazolidinediones are said to be contraindicated in acromegaly. In situations where the patient is not controlled on metformin or GLP-1 analog, one can go for SGLT2 inhibitors, but remember that if the acromegaly is quite uncontrolled, there could be a risk of euglycemic diabetic ketoacidosis with SGLT2 inhibitors, so be careful. And if the patient is not under control, then of course, basal insulin, and if needed, basal bolus insulin is something that will be required for controlling their diabetes. For hypertension, we haven't come across any specific drug preferences. Maybe Dr. Aruj or Professor Najam can comment if there are any specific drug preferences, antihypertensive preferences for hypertension.
To my
So,
knowledge, there's no specific preference, but I think in the guideline, Uruj was showing that is inhibitors and ARBs as
yes, sir.
per the recommendation. Am I right?
Yes, sir, that is recommended. ACE inhibitors or ARBs are recommended.
Thank you
But
so much.
next, please.
Okay. So thank you so much for this detailed answer. So we have another question, that how to tackle with disparity in IGF-1 levels and growth hormone while assessing the response to treatment and monitoring. So Dr. Najam, would you like to comment, please?
Obviously, IGF-1 levels are, I mean, we sometimes do face this problem. IGF-1 level from one lab is different from the other lab. I think we have to use a reliable lab first of all. That's number one. दूसरा ये था कि labs में age specific और gender specific ranges होते हैं, वो follow करना ज़रूरी होता है. और अगर disparity हो कि IGF-1 से तो फिर I use the OGTT with growth hormone testing to see what is the result on that. To see whether if it is cured by OGTT criteria and IGF-1 is raised, then you have to give weightage to the OGTT with growth hormone testing if there is a disparity.
Okay, sir. Thank you so much. And I hope this clears the query of
To add to this, to add to this,
Yes,
there are some conditions which can lead to disparity, because sometimes starvation and liver disorders and other disorders do affect the IGF levels. And then OGTT with growth hormone, as sir has mentioned, is the test to be done to find out, to monitor the treatment and response to the treatment.
Okay. Thank you so much. Then I have another question, which in which the audience is asking that they are saying thank you for detailed, well structured, and nice presentation. So keeping in view the treatment limitations. So as these patients should usually be discussed in pituitary MDT for the best possible care, I was wondering if it's something regularly done in Pakistan. This is by Mohammad Zahir Shah. So he wants to know if there is something regularly done in Pakistan, any MDTs.
So in at least in Karachi, we know that it's almost more than a decade that we are holding these pituitary MDTs very regularly, and all the complex cases are discussed in those MDTs. I'm not very well aware about what is the situation in rest of the Pakistan, but through these guidelines and these webinars, we will like to emphasize the importance of holding pituitary MDTs, because this is the way forward to improve patient care, to um, be effectively managing all those complex and challenging cases. If you have an MDT where there is a neurosurgeon, the radiation oncologist available. Similarly, we know that right now therapies are based upon the tumor histopathologies as well. So adding a histopathologist in those MDTs would be really valuable. So this should be regularly done. So at least in Karachi, we are doing. Dr. Aruj is part of, Professor Najam is actually under his leadership, this has all started. So these are done as a regular practice in here.
I would like to second that, because pituitary MDT is important and that should be done in all big institutions when neurosurgery is offered for patients with acromegaly or any pituitary tumors. If to my knowledge, they are not being practiced in other cities and centers. I think we should recommend, and we should be encouraging the faculty there to start within the institutions.
Yes, sir. Very rightly said that we should be emphasizing the importance of this MDTs on pituitary tumors. So the next question we have that how to manage diabetes and which drugs are preferred. So I think Dr. Aisha has already elaborated very well given this answer. So how long? Next question is how long in patients with persistent disease do we wait after radiotherapy for effect of medicines to take effect and decide for referral to reoperation? So,
So,
Uh,
Dr.
you want me to answer या कोई
please,
और
sir,
लेना
sir,
चाहते
sir, please, please.
देखिए the जो radiation के बाद the duration uh, for the radiation to be effective is variable. If you are doing radiosurgery, the duration is shorter, and if you are doing the conventional radiation, it takes even longer, up to 8 to 10 years for the IGF to normalize. और फिर इसके साथ तो 3 to 5 years तक है with radio surgeries. So you have to wait, and once you have given it, I think you have to wait. And doing a surgery after radiation has been given is difficult as well for for the neurosurgeon, because the tissue becomes fibrotic and difficult to operate on them as well. So know the time period. Okay, it takes 3 to 5 years after radiosurgery and even 8 to 10 years after conventional radiation, and we should be treating those patients in the meantime with medical treatment.
Okay, sir. Thank you so much. So now we have another question that are there any targeted therapeutic agents?
So targeted therapeutic agents are under developmental phase and some are already approved, but we have to wait for more clinical trials on those agents and approvals through drug agencies before these will be available for routine clinical practice. Dr. Aruj has already pointed out certain newer agents that are available in the West, but not to our usage in here.
Okay. So thank you so much, Dr. Aisha. There's another question which I would like you to answer that how Pakistan Endocrine Society Forum can help for arranging drugs in Pakistan for especially patients easily which are not available in Pakistan. So basically they are asking for arranging drugs for patients here in Pakistan.
Okay, so we communicate this to different pharmaceutical companies regularly about the drugs which are not available in Pakistan but are needed for our patients. Um, the drug approvals in Pakistan is a lengthy process, and then there are many factors involved whether a particular pharmaceutical industry has got that plant available to manufacture that compound in Pakistan or not. Similarly, because of the fact that we have a lot of restrictions because of our debt status with the IMF. Because of those restrictions, the companies are not able to bring a lot of drugs which they could otherwise have been able to bring. So we are trying our best from our forum of Pakistan Endocrine Society, but have to see the impact. Don't know whether how much time will it take, but definitely these are already on our cards, and we are trying to get hold of essential. Rather, I would say that needed drugs that are needed for important drugs which are needed for endocrine conditions.
Thank you so much, Dr. Aisha. There's another question that what are indications, clinical or lab parameters to start growth hormone post surgery and approximate cost per month? So if Dr. Rooj would like to answer.
So, for the clinical indications are actually the performer. You have to fill the performer. And there's a scoring which is done to see how much patient has the symptoms. It's 11 points. You have to have a score of 11 point or 7 and above, and then it is decided clinically. Lab parameters, you have to do the growth hormone levels after insulin tolerance. So you see the levels, how much levels are high. You can see the IGF, it is very suppressed. It is also one of the lab parameters which can be used. Growth hormone injections are pretty expensive because it's around 6 to 10,000 one pen costs, which is used for a week or two. So depending on the requirement of the patient, so it gets really difficult for the patient to obtain these injections.
Let me
So
add here, क्या कहते हैं, growth hormone deficiency in adults is a topic which not just applies to acromegaly patients getting growth hormone deficient, but applies to all of the pituitary tumors
yes, sir.
who undergo surgery and radiation. And the reason why this has not picked up in Pakistan is the cost. The cost of a growth hormone replacement in adults is different from the growth hormone replacement in children. Uh, and the second is the availability of the growth hormone. Uh, Even we are having shortage of growth hormone for children. That is the reason. And the symptoms, as Uruj has pointed out, has to be a quality of life questionnaire has to be filled. And if they qualify, then you offer them treatment and you have to reassess them after 6 months and see if they benefit in terms of the quality of life improvement. And if that is the case, then you continue it. Otherwise, you discontinue it. So this concept of growth hormone deficiency in the adults has been is in practice in the Western world since mid 90s, uh, but it has not picked up in Pakistan because of the reasons I have mentioned.
So, thank you so much, sir. There's another question for you that can we start for cost concern combination of dopamine agonist and octreotide first, or go for somatostatin alone, if IGF-1 is less than 2.5 fold, as more somatostatin dose will be required, which is more costly.
देखिए अगर वो 2.5 से नीचे है तो then I think we should be starting on cabergoline to those patients. If it is more than 2.5, we should be aiming for sandostatin, which is available. Lanreotide is not available in Pakistan. If cost is an issue, where there are patients who say, we cannot afford that sort of medication because we cannot afford that. So in that case, you have to, we have no other option but to go on for um, cabergoline, which not going to be not very effective in those patients who have a very high levels. So there's no easy answer to that. Uh, and sometimes you have to combine them together, as Uruj has already told you. But again, there are patients sometimes whom we accept raised growth hormone levels while the radiosurgery is working because we have already tried or the patient is being tried on cabergoline and they cannot afford sandostatin. So there's no easy solution to this problem. ये जिना वगैरह में बैतुल माल से अरेंजमेंट होता है, लेकिन आई हर्ड कि उसमें भी कंटिन्यूटी नहीं होती.
नहीं सर, आजकल उसमें भी प्रॉब्लम हो रही है. इंडेंट हो जाता था हमारे पास, जो वो भी नहीं हो रहा है. और जो है बैतुल माल से भी 3 से 6 इंजेक्शन तो हो जाते हैं, फिर उसके बाद इश्यूज आना शुरू हो जाते हैं बिकॉज और लोगों को भी तो देना है उन्होंने, तो प्रॉब्लम हो रही है हमें. तो कुछ तो लग जाता है, कुछ पे फिर आगे प्रॉब्लम
हाँ, अगर आप इंटरमिटेंटली लगाएंगे तो उसका तो बहुत ज्यादा फायदा भी नहीं
फायदा
मिलेगा.
नहीं होता. जी सर. सो कैबरगोलिन ही रह जाती है बस फिर.
There is another question in continuation that can we use bromocriptine instead of cabergoline if cabergoline gets short or unavailable?
Yes, you can use cabergoline. Why not? But again,
Bromocriptine.
They're asking
sorry,
bromocriptine.
bromocriptine. Yes, you can use. If cabergoline is not available, yes, you can. But again, I think the cabergoline is more effective as compared to bromocriptine.
And the decision should also be based upon the fact that we know that this will be effective in cases of mild disease, people who have co-secretion of prolactin as well. Um, Remember that dopamine agonists are not the primary treatments. They can be used as adjuvant treatments. They will not be as effective as somatostatin analogs. And if we look at the data of cabergoline versus bromocriptine, the effectiveness of the cabergoline is more remarkable compared to bromocriptine. So it would be like a choice in situations, desperate situations, but we don't know how much effective bromocriptine on its own alone in such situations will be.
Okay. Thank you so much, Dr. Aisha. There's one more question left that can reinitiating growth hormone after cure of disease can cause recurrence of tumor growth. So they are basically asking if giving growth hormone after cure of disease, can it lead to recurrence of tumor?
Professor Najam, would you like to answer this question?
Okay, this concern was always there, and I think people are careful about it. But I think it's not been substantiated in the literature that it leads to recurrence of the tumor. There was concern when it was this adult growth hormone deficiency was introduced in mid 90s. Like since then, this issue of recurrence of the tumor has not been substantiated in the literature. So uh, the likelihood is very, very low.
So thank you so much. So the question and answers have come to an end. We are also the ready poll results are ready for display. We can also look at that. So panel of experts would like to comment the pre and post session response.
Okay, maybe Uruj, would you like to take it up?
So seems like post session they have come to know that the first option of the treatment in acromegaly is transsphenoidal surgery because 80% of people are there are still people, but 80% of them have gotten this right now. So can I go to the next question?
As against 53%.
Yes, initial 53%. And again, one more than this is this must be very confusing for everyone. 0.4 nanogram. We are looking at ACE guide. I'm saying here, question is ACE guidelines. So that's the American Association of Clinical Endocrinology. So their cutoff will be 0.4 for us. Pakistan, if it was PES guidelines, then the cutoff would have been 1 nanogram per ml. So still, 32% have got the 0.4. Now it's a confusing question, I must say. So I'll give the benefit of doubt. But yes, compared to 10%, 32% have come to know about this, and 54% are knowing the more than 1 nanogram per ml levels as well. So I will say that, yeah. Next, please. And yeah. So it was a pretty good, easy question. The female who had acromegaly and was confirmed and was started on pegvisomine. So the question was, what is the mechanism of action of pegvisomine? So 79%, 73% and 79% people know that it's a growth hormone receptor antagonist, which is excellent, I think. So good results, I guess. What do you think, Sir Najam? What do you think of this?
Yes, I mean, obviously, there's been a very minimal improvement in this pre and post. The second, third question, so people had already this knowledge before the presentation. In the first two questions, I think there was an improvement in the post-session response.
Thank you so much for the results and for your insightful comments. So I would like to ask if our panel of experts to give some key messages to our attendees.
I think the message is that attendees please read the guidelines which have been developed for the low and middle income countries, and try to adopt that in your practices, and so that you manage the patients appropriately. Try to develop pituitary MDTs in your institutions, um, and so that the management of your acromegalic patients are up to the mark.
Thank you so much, Doctor. And Dr. Aisha, you would like to give your valuable insights, please.
Yes, so thank you very much, Dr. Vasva, for moderating this session so wonderfully well. And thank you, Aruj, for a really nice, comprehensive presentation on acromegaly guidelines. This is the work that we have been doing for last couple of years, and alhamdulillah, the guidelines were published last year as a supplement. It's available online on JPMA supplements page, and you can access the guidelines from there. And this is something which is tailored for the lower middle income countries, as Professor Najam has already pointed out. The thing is that We need to be abreast with the knowledge in managing these patients. Remember, patients who have functioning adenomas, you would like to reduce that hormonal hypersecretion and at the same time look at the other hormonal deficiencies which are there and replace them adequately. If they are hypoadrenal, remember to guide them about the sick day rules of increasing their steroid doses in cases of illnesses. Similarly, keeping a close follow-up of these patients, looking for comorbid conditions, screening for comorbid conditions, and establishing pituitary MDTs, as Sir has already pointed out, and we have discussed this earlier as well. And thank you for the questions that you posed for Pituitary MDT. That is the way forward. If you want to improve the care of a patient with a pituitary disorder, any pituitary tumor, whether it's a functioning adenoma or a non-functioning adenoma, managing that patient through a pituitary MDT actually improves their care. So thank you very much for your kind presence, and thank you, Professor Najam, for your valuable input and your guidance throughout the guideline development phase. And thank you, our IT team, Mr. Anas and Mr. Atif and Harun Michael for your administrative and technical support throughout. Thank you, Vasco.
Thank you so much, Dr. Aisha. And in the end, I would like to invite Dr. Ruch for her concluding remarks if she wants to add something.
Thank you so much, Vaspa. A lot has been said already, and I just want to say, as Dr. Najam said, that our professionals need to go through these guidelines, which have been tailored for this country and people of our people, depending on the resources we have. And I agree with Dr. Aisha that the step forward would be the CMEs and more educational programs regarding these guidelines. Thank you so much. Thank you so much for having me. Thank you.
Thank you so much, Dr. Ruj and Dr. Aisha and Professor Najmul Islam for being the wonderful panel of experts and the wonderful presentation. And I would also like to thanks to our participants who have been actively participating in during this program and for the wonderful questions. And I hope many of the participants by these questions it has been possible for them to clear their queries. So with that, we will conclude our session. And so
Thank you, everybody. Khuda Hafiz.
Thank you. Allah Hafiz.
Thank you very much. Allah Hafiz.